Okay, so those are the obstructive diseases. Questions on that? Not too bad? Okay, so let's get into restrictive diseases. Restrictive diseases, there's some symptoms that you should see. They tend to use their neck muscles to get air. Remember, restrictive diseases, you're thinking of the balloons to make balloon animals. It's hard to get the air in, it's easy to get the air out. So they tend to use their neck muscles to try and gasp for a little bit more breath to try and get it in there. All right, they use their neck muscles to do that. They're usually having cyanosis because it's difficult to get air into and oxygen into the lungs. And auscultation, they have these crackles, which again, it sounds like you're rubbing hair against your ear, but some people like to say that it sounds like Velcro. But again, it's down here, it's not up here, right? So the one I use as a good classic one is Idiopathic Pulmonary Fibrosis. And this is where the fibroblasts, we don't know why, but the fibroblasts start laying down collagen and elastic fibers. And it starts putting it all around the alveoli, and it's making it so the alveoli has problems expanding because there's a lot of scar. It's making scar tissue, and it's making it so that it can't expand. That's what's happening here. So restrictive diseases is restricting the lungs to expand, all right? So the alveoli don't want to expand. That's why it's called restrictive. Difficult to get the air in. Think of the balloon animals that we talked about, okay? Etiology, like I said, is idiopathic. And what we tend to do for treatment for these people is to give them corticosteroids. Corticosteroids is going to decrease the fibroblasts from producing those obnoxious amount of elastic and collagen fibers. So that'll cut down on it. However, these people will have to be on long-standing corticosteroids. They'll be on it for months and months, if not years. What's the problem with putting someone on corticosteroids for a long amount of time? What disease will they get?
Yeah, you get like thrush and infections.
You could get that, but what's the major thing that we're concerned about with that? What's that? Cushing's, right, Cushing's. Yes, you could, because it decreases your immune system, and that's why this happens. There's a whole bunch of different things. But the big thing that we're worried about is Cushing's, right? And we saw that Jerry Lewis, I kind of showed you that before, where he had idiopathic fibrosis, where 1 year ago he looks like this, and then next year he got this moon face. Right? And Cushing's syndrome has all those things. Your immune system goes down, which is all a part of that. You get osteoporosis, your immune system. There's a lot of things that happen with that. So this is a good time for, what I'm saying is when you study the respiratory, I know that's the only thing, that's one of the things that are going to be on the exam, but if you see the word Cushing's on there, we went over it, take the moment to go back and read what Cushing's is. Would I ask you on the test on this one? No. But you got to, the final exam is coming up. So you might as well start studying for it and making sure, well, he's mentioning Cushing's, I should go back and see what that's all about. You know, to reinforce it for yourself, okay? All right. Acute respiratory distress syndrome, ARDS. Bad news, okay? This is not something you want to get, all right? ARDS, this is a medical emergency. Basically, you are destroying the alveoli, and you're destroying usually that and the capillaries, okay? What's happening here is that it could be caused by bacterial sepsis, smoke inhalation, burns. This is what kills people. It's not that it's just the smoke is going inside. So in a burning building, you're breathing in smoke. It's not the smoke, or the substance of smoke that's actually going to kill you. It's that the smoke is very hot. And that temperature is going to burn your lungs and turn them into doily paddles. It's just going to put holes in the lungs. Does that make sense? Because the smoke is hot. Heroin overdose, aspiration of vomit. When you breathe, or I'm sorry, when you upchuck, you want it to make sure it goes out into the toilet. You don't want it to go into your mouth and then it goes down the trachea into your lungs. Besides cookies that you're throwing up, you're also throwing up the acid, which has a pH of 2. That acid will go down into your lungs and burn holes right into your lungs. And if it burns holes in there, they're going to have dead tissue, and that dead tissue, which is necrosis, is a wonderful medium for bacteria to grow on. All right? So you don't want, that's the whole reasoning why you don't want to have anything in your stomach. You can't eat before surgery. They got to make sure that that stomach is empty. All right? I had two patients, and they were fairly young, 30 and 40 years old, and both of them died because they said to me and to the anesthesiologist, oh no, I didn't eat anything for 8 hours. But then why do you have food that wasn't digested that came out of the stomach when they were trying to intubate? Because we have to intubate to do, and then we did a simple procedure. It wasn't a C-section, it was 2 D&Cs. All right, it's a dusting and cleaning, which we'll get into later. But they just had this routine, not routine, but we had just a small same-day procedure. But now these two people went down into their lungs, and now they went to ICU, and then 2 days later, they just died. Not a good thing, okay? Now, in pregnancy, that's difficult. We always say in pregnancy, we'll learn about it, it's hard to get rid of, the peristalsis happens very slow during pregnancy. We always assume that the stomach is not empty, okay? So in that case, we do surgery. But the doctors are all, they're all prepared for something like that. So they make special precautions. And we hear, when's the last time you ate? Because when you're in labor, you're in labor. You were eating at McDonald's or whatever, you're in labor. You can't help that. It just, that's what happens. But when you have something like let's say an elective surgery that you were supposed to not eat 8 hours before, and then they go ahead and do it, it's not a good thing. And it was bad for both those situations. If you know somebody, let's say your mom or dad, God forbid, aspirated, and they're down in Florida, okay, and now they're in intensive care, please, I'm okay with you not coming to class. Just drop everything and go down, because you might not be able to see her, all right? That's not a good thing. When you see that someone aspirated or someone who has ARDS for whatever reason, it's not a good sign, okay? So the alveoli gets damaged, gets collapsed with each breath, and it has about a 40% fatality rate. I think that's a little bit high. It should be a little bit higher than that. It's not a good thing, okay? All right, and then we have a whole list of pneumoconiosis, which is basically occupational lung diseases. What this is happening is that these are people that are working, let's say, to give an example, are working in the mines, and they're there for like 20 years working in the mines, with the zinc mines and things like that. They're breathing in all this dust over, let's say, 20 years. Some of this dust, zinc or silicon or coal, anything, is going into the lungs, and now that's a foreign body in the lungs. So your immune system sees it as a foreign thing and starts putting scar tissue all around there to try and block it from, they think it's going to destroy your body. So your immune system is working with it appropriately. It's going to put scar tissue all around there, thinking that it's going to destroy your body. So it kind of wards it off. But when you have a lot of those areas in your lungs and it starts making a lot of scar tissue, then what's going to happen is that lung is not going to be able to expand. And that's what happens with this. Again, that's your restrictive lung disease. It's going to be difficult for it to expand. Okay? Atelectasis. Atelectasis, atel means incomplete. Lectasis, as I showed you before, is dilation. So this is that the lungs are, the alveoli are unable to completely expand or dilate. Okay? So it's incomplete expansion of or collapse of the lung. Now, I just want to make a point here, because we're going to talk about this too. This is not a lung collapse from a pneumothorax. This is different than that. All right? So don't get mixed up. Lung collapse, this is where the alveoli kind of collapsed on themselves. It's kind of like a balloon that's kind of collapsed. It's not that something from the outside is pressing down and the lungs can't expand for that. That's lung collapse, and we'll talk about that. But this is that the alveoli, how they kind of like close up and they're not going to be able to dilate. All right, so it's nothing from the outside world or outside of the lung. So not all of them are reversible. Most of them are, but not all of them. And a lot of reasons why you have them. The most common cause is post-operative complication. These are Usually someone has abdominal surgery for whatever reason, okay? And the problem is they can't take a deep breath. And it's appropriate. If I had abdominal surgery, I mean, it's difficult to take a deep breath because when you take a deep breath, your diaphragm goes down, which means that the intra-abdominal pressure will increase, which means it's going to expand your abdomen, which means that that scar that's over there, it's going to put pressure on it, and that hurts. So it's appropriate. But we got to get them to get as deep of a breath as possible because we don't want those alveoli to stay collapsed. So what we do is that a patient doesn't want to inhale because of all that pain, so we give them something called incentive spirometry, this little thing that we kind of, well, I'll show you what that looks like. It kind of gives them an incentive to take a deep breath. Another cause of it can be premature newborns. There's a decrease in surfactant, and then that's going to increase surface tension, and the alveoli stay collapsed. So, and then all other things on there too. So this is incentive spirometry. Who here has seen this at a patient's bedside? Yeah, most of these have seen this, okay? So you take this thing over here, and do you blow into it? You suck, right? Not you suck, but yeah, you suck in. You suck in, right? You suck in, right? Because what it does is an incentive to inhale, not an incentive to exhale, an incentive to inhale. So when you suck in, what happens is there's usually a ball over here or some kind of lever, and it usually will tell you how much air went into your lungs. So you blow, you actually suck this in, and you want to try and get it to like 5 liters to get in there. And each day you get better and better. It's easier to have the person walk, like that's why we always want to get the person, if it's not like due to surgery to the legs, but something abdomen, we usually want them walking the next day. As you're walking, that's incentive enough to take deep breaths, because you're walking like that, you're going to be breathing that way. But if you're going to be in the bed, there's no incentive to do that. Now, what I and a lot of doctors do, we on the week before, where we got to do all the consents and sign all the papers and stuff, I'll give my patient this the week before and let them practice what that is, sucking in and what the whole thing is, so they have an idea of what to do, because we want them to do this even in the post-op area. We want them to start doing this before we take them to the floor. They can take deep breaths. Well, you're a little groggy at that time, but if you have an idea of what this machine is or this little apparatus, then it'll help you a little bit. So that's what we usually do. In children, like 4 or 5-year-olds, we have these little games that you can play. Try and get it to the bird, try and get it to the owl, so they have little games that they try to do. They make it a little bit of fun, all right? So yeah, those little things like that. Okay, those 3 types of atelectases, okay? Most of them are reversible. So we have something called obstruction or resorption atelectases, okay? And this is where the airway is blocked and any air distal to the site gets fully absorbed. So it gets absorbed into the bloodstream so that there's nothing left, so it just collapses on itself. But we can't get any more air in there because there's something blocking it, and it's usually a mucus plug. Okay, that's doing that. All right. We also have something that's reversible. We just have to remove that area, whether it's asthma, cancer, whatever, foreign body, but that is reversible. Then we have compression atelectasis, and this is where something is pressing against the lungs and not allowing air to actually enter back into the alveolus. All right, cancer is a good example of this. That's some sort of cancer is pressing on the area there. That too is also reversible as long as we can remove the agent that's causing that. The one that's not reversible is this contraction atelectasis. This is when you have scars in the lung or the pleural that constrict the lung and it is collapsing the lung. Okay, this is irreversible. TB is a good example of this. So this picture here is kind of showing you 3. This is resorption or obstruction over here. Here's compression, something's compressing it. But there's contraction. It kind of looks like the whole lung has been scarred, and it's got a lot of contraction going into it. You're not going to be able to stretch it out because there's so much scarred tissue over there. okay? You can't fix that one to the lung transplant.